find the officials of Pathogen Folbigg is resumed.
Yes, Ms. Furness.
Thank you. Your Honour, this morning we have Professor Clancy and Professor Blackwell. Professor Blackwell will be wearing a hearing loop to aid her hearing, and we hope it works well.
Thank you. Would you swear the witnesses, please?
Just stand faces on it, please. Sorry? Just stand faces on it. Would you like the oath or the affirmation? Would you like the oath or the affirmation? Would you like the oath or the affirmation? Would you like the religious promise to tell the truth or a promise to tell the truth?
Yes,
Which one?
I would prefer to affirm.
Okay, just stand faces on it, please.
Affirm.
Yeah, just stand faces on it. Do you solemnly, just faces on it?
Yes.
Do you solemnly sincerely declare and affirm that the evidence you shall give be the truth, the whole truth, and nothing but the truth?
I
Yes,
do.
I do. Thanks. Oath or affirmation? Would you like the oath or the affirmation?
Whatever.
Whatever you like.
Not the oaths.
Just stand faces on it. Do you swear by Almighty God that the evidence you shall give be the truth, the whole truth, and nothing but the truth? Yes, I do.
I do. Thank you. Just take a seat there, Ms. Dr. Clancy. Yes.
Thank you. Your Honour, Professor, the hearing loop has a volume switch. Perhaps a court officer will increase the hearing, the volume, if
This
is it working?
It's working well,
Okay.
thank you.
Here's a spare.
Right.
Thank you. Can I start with you, Professor Blackwell? Will you tell the inquiry your full name
Cecilia Caroline Blackwell.
and your occupation?
I'm retired, but I'm working as a conjoint professor at the University of Newcastle.
Thank you. And you have provided 3 statements, and I'll take you through the detail of them later. One is entitled Inquiry into Convictions of Kathleen Megan Folbigg, and that document, which is dated the 5th of March 2019, was, I understand it, a document you prepared at the request of those representing Ms Folbigg. And the contents of that's true and correct, Professor? I tender that, Your Honour.
T.
And then there is a second document headed Advances in Diagnosis and Mechanisms Associated with the Pathology of Sudden Unexpected Death, and that document was prepared at the request of the inquiry. And I'm not sure that it's dated, but you provided that recently in March.
Yes.
That's right. And then there is a third document. Oh, I tender the second one, Your Honour.
U.
A third document dated the 13th of March, which is a supplementary report for the inquiry concerning Caleb, and that arose from the first report that Ms Folbigg's representatives engaged you to perform. That's correct? I tender that too.
Exhibit V.
Now, turning to your qualifications, Professor, you have a Bachelor of Science, a Doctor of Philosophy from Stanford. What was the topic for your doctorate?
Medical microbiology.
I think you might have to sit a little bit closer to the microphone if you could.
Medical microbiology.
Thank you. And you have a Doctor of Science,
Yes,
and you're a Fellow of the Royal Society of New South Wales.
yes.
Now, you're not a medical practitioner.
No, I'm a medical scientist.
Thank you. You've said that you are retired, but nevertheless a conjoint Professor of Immunology and Microbiology at University of Newcastle. Is that a full-time position?
No, it's part-time.
Is it effectively honorary, or do you actually work in that capacity?
It's an honorary appointment, but I have, for personal reasons, I haven't done a lot of laboratory work the past few years.
And you have in your CV that you're visiting professor at the Faculty of Medicine and Health Sciences at the University of Newcastle. Are you still holding that position?
That was when I came in 1999-2000 for a sabbatical.
You no longer hold that position?
No, I'm now a conjoint.
I see.
professor.
Thank you. Now, you have contributed significantly to the profession in your area of microbiology, haven't you, Professor?
Yes, and interface between microbiology and immunology.
You've were given an Excellence Award by the International Society for the Prevention of Infant Deaths for your work in the role of infection and inflammation in sudden death in infancy in 2014.
Yes,
And you've published very widely in the field
yes,
and presented extensively at conferences domestically and internationally.
yes.
Thank you. Now, I'll come back to you, Professor Clancy, so
Yes.
don't feel abandoned. Coming back to your first report, Professor Blackwell, if you have that in front of you, the first 11 paragraphs of your first report concern events that occurred back in 2000 before the trial of Kathleen Folbigg. You see that there?
Yes, the first page.
Yes, the first and second page, really, the first 11 paragraphs. And then you answer the question, what matters could possibly be eliminated or require further investigation? And you then go through a number of matters, and I might just take you through some of those if I can. You first deal with metabolic disorders, and your conclusion at the top of page 3 is that further investigation should include genetic assessments by whole genome sequencing. Now, do you understand that the inquiry has obtained samples from each of the children and Ms Folbigg and is currently having that material sequenced, both in terms of the whole genome and, in respect of some, the whole exome? You're aware of that?
Yes.
And that is the sort of work that you consider should be done now in respect of the children that will indicate material or results that were not known back then?
It certainly would, yes.
I beg your pardon?
It would contribute.
Thank you. Now, coming to paragraph 15, this is on page 3, you refer to the swollen uvula in Sarah might have resulted from inflammatory responses to respiratory infection.
Yes.
Now, I note that attached to this report there is instructions, which are tab A, and it's a bit confusing because there's different tabs, but perhaps if I can ask you to turn to page 16, which is the end of that report I'm now addressing with you, and then the next document has an A on it. It's page 1, instructions. Can you find that?
Yes,
And then the next page is your professional experience and qualifications.
yes,
And then the next page seems to be the same question, a similar question, but not in precisely the same terms to the one I've just taken you to. This one is, what factors can be eliminated from further investigation in relation to the deaths? Do you see that? The matters that are set out on that page 3 and following pages, were they a draft, as it were, an earlier draft of the answers that you provided in your report proper?
yes, I use that as a basis to prepare the second report.
I see. And so you prepared this draft yourself,
Yes,
and then from that you prepared the final report,
yes.
and you annexed it for completeness.
That particular draft, I think, is the one I prepared for Mr. Chrisenthal.
I see. So that was the one in 2000.
Yeah,
And-
2004.
2004 or 3? Nevertheless, it was around about the time of the trial.
No, it was after the trial.
I see. So originally in 2004 after the trial, and then updated in 2006.
Yes,
So in the, if I can call it the earlier report, now paragraph 4, this is on the document that's headed page 3, you say there's little evidence that the swollen uvula in Sarah was associated with her death. Do you see that?
yes,
And then in the current report, which is at paragraph 15 on page 3, you say that the swollen uvula in Sarah might have resulted from inflammatory responses to a respiratory infection.
yes.
Why the change?
No, I think that there isn't much evidence that the swollen uvula was blocking her breathing.
There wasn't much evidence.
I don't think that that was blocking her breathing. And looking at the evidence later, the more detailed consideration of the inflammatory response that was probably going on, this is probably reflecting her response to the infection.
So you are still of the view that there's little evidence it was associated with her death.
I don't-
However, you're noting now that it might have been caused by an inflammatory
It
response.
might have been caused by the inflammatory response to the bacteria that were isolated from her.
Thank you. Now, in relation to Patrick, I'm back on the first report now, or the final report, I'm sorry, I should describe it as, on page 3, encephalitis in Patrick. You refer to various matters in those few paragraphs, and is it effectively the case that the sequencing that the inquiry is organising will assist in providing, or may assist in providing, more information about Patrick?
Right. At the time of Patrick's death, there weren't DNA screening methods for viruses. So to eliminate that possibility, that would be one test that could be done to try to further determine what was going on in the child. In 2012, Professor Morris published a paper about reassessment of slides of cerebrospinal fluid. And this might be useful in relation to looking at what was going on, if the slides are still available. And I don't know if they are.
Thank you. Now, coming to paragraph 21, immunodeficiencies, in your second sentence, you say there are indications in the children's medical histories to suggest that they had more frequent or more severe bouts of infection, and then the whole genome sequencing may assist in that regard. Now, the evidence that is before the inquiry and was before the trial from those who had treated the children prior to their death, particularly the 3 older children, was that their presentation to doctors, and in some cases emergency, was no different from most other children in respect of respiratory matters. So with that background, can I ask you your source of information about they had more frequent and more severe bouts of infection?
Reading the notes, the children seem to have quite a few infections.
Sorry, reading the what?
From reading the notes and the information that was presented at the transcript of the first trial, it seemed that the children were reported to have more infections. That could have been perception of people caring for them. What I was referring to were the classical immunodeficiencies that Dr. High would probably be looking for. And I don't think there was any evidence of that in any of the children.
I don't quite understand that. Is it your expert opinion from the material you read at the time of the trial that allowed you to form the view that they had more frequent and severe bouts? Is that what you're saying?
What I'm saying is that I don't think any of these children had classical immunodeficiencies. From the medical histories, they seem to have attended the doctor for various coughs, colds and flu. I've never had any young children, so I don't know if that was normal or if that was more frequent. But certainly infection and referral to the GP for treatment seemed to come up in some of the material that I read.
You'd accept that their GPs, who saw not only them but presumably many other patients, who formed the view that there was nothing out of the ordinary with their presentations, you'd accept that they would be in a better position to determine...
The GP's notes on the children would merit review.
Thank you. Now, you then refer to what factors need further consideration, and I'll take you over to paragraph 24, which is the IL-10 gene hypothesis. Now, again, with the sequencing being undertaken on behalf of the inquiry, you would expect there to be some more information known about the role that that gene may have played in respect of these 4 children.
This particular study, or the report by Dr. Drucker, only looked at one of the IL-10 genes.
I'm not referring to, can I just stop you there? I'm not referring to Dr. Drucker's work. I understand Dr. Drucker's work. What I'm suggesting to you is that the question of the role of the IL-10 gene will be addressed in respect of the 4 children by way of the whole genome and the whole exome sequencing of each of them and Ms. Folbigg. That's right?
Yes, and it will give you information not only about IL-10, but about the other inflammatory genes and their variations that might be present in these children.
Thank you.
At the time Dr. Drucker did these tests, they were quite laborious, and you could only test for 1 or 2 genes at a time. The sequencing will be much more useful and much more easily to analyse.
Now, coming over to page 8, you refer in paragraphs 36 to 39 about the various organisms found in each of the older children and express the view that they are important.
Yes.
Now, His Honour heard from 4 forensic pathologists yesterday who I think it's fair to say each was satisfied that those coliforms and other organisms you identify were contaminants from the post-mortem. Do you accept that their opinions, based on their experience as having seen many people or many bodies in these circumstances, should be reliable?
Right, this is a contentious area. There are recent papers on the microbiology, post-mortem microbiology and sudden infant death. And I've noted some of these. Professor Morris from Lancaster looked at over 5,000 autopsies, mainly adults, but there were 1,108 perinatal deaths and 468 SUDI.
Just let me stop you there. Professor Morris's qualifications and experience are what?
He is a pathologist at the University of Lancaster.
Thank you.
And with a major interest in the role of inflammation and infection in sudden infant death.
He's a clinician.
He's a clinician.
Thank you.
What you have to think about in assessing microbiology is, if careful precautions are taken to obtain the sample aseptically, about 2/3 of the blood samples are going to be negative. So contamination, even under less than optimal conditions, is probably not a major consideration. Post-mortem interval had very little effect on the isolation rate of the organisms. And
Sorry, are you quoting from Professor Morris at the moment?
Yes.
Thank you.
And this was confirmed by Dr. Weber and his colleagues from Great Ormond Street, who looked at 507 SUDI investigations. And what they found was that if the child was examined within the first 2 days, you actually found more bacteria, more evidence of microbiological infection than if you looked later. So the idea of translocation and breakdown of the mucosal barriers has to be taken with a grain of salt.
Let me stop you for a moment. Are you referring to a 2004 publication by Professor Morris?
No, I'm referring to his 2006 publication.
So you just need to tell me where I can find that.
It should be in the reference list.
I'm referring to the heading controversies on page 8, and there's reference to Webber in 2008 and Morris in 2004. So if I can just ask you, if I go to your references at the back, we have Morris, a number of references to Professor Morris. There's a 2006 Postmortem Bacteriology,
That's it.
and then there's a 2012 Postmortem Cerebrospinal Fluid. That's not the one you're referring to, it's the 2006.
2006 Postmortem Bacteriology.
And in relation to Webber,
Webber 2008 and 2010.
thank you. Now, is it the case that, in your opinion, the research you've referred to should be preferred to the evidence of the forensic pathologists as to what they observed in each of the children or observed on autopsy as being contaminants?
The work by Professor Webber and his colleagues is extremely thorough, and what they suggested is the proportion of positive cultures decreased when the samples were taken later than 24 hours.
Could you answer the question you were asked? Could you answer the question you were asked?
The question was, do you believe, in your expert opinion, that the inquiry should prefer the research that you've identified, the 2008 research from Professor Morris and the research from Professor Webber, to the evidence of the forensic pathologists who have either observed or read the autopsy reports as to the findings in each of these
The
children?
work by Professor Webber was on 507 postmortems.
Could you answer the question you were asked, please?
But the question, I'll answer it. Forensic pathologists are dealing with all ages and conditions. The post-mortem on the sudden unexpected death in infant autopsies, I think, provides better information about the idea of contamination.
However, the 4 forensic pathologists who gave evidence were performing or reading the results of the performance on autopsies of children, at least 2 of whom were thought to have died from sudden infant death. So they were performing the autopsies on children, infants.
Yes. What I'm saying, this was a retrospective review from a major teaching centre done by a small number of pathologists. So the conditions, the protocols, and the techniques would have been probably as standard as you're going to get.
So I take it from your answer that your opinion is that this inquiry should prefer the results of those researchers over the evidence of the forensic pathologists as to their opinion as to what they saw or read about, for the reasons you've given.
I wouldn't say prefer, I would say consider. That they should consider these, I think, very valid and extensive studies that have been done specifically in relation to sudden unexpected death in infancy.
And what is your opinion as to the results of that consideration?
The results of that consideration is that microorganisms probably contribute to a proportion of these deaths.
Probably.
Probably.
And that's on the basis of the research and taking into account the forensic pathologist's evidence, or putting that to one side?
I wouldn't put aside the evidence of the forensic pathologists. What I would say is that this group of forensic pathologists are of the opinion that infection may play a role in sudden infant death, and that finding organisms like Staphylococcus aureus or Escherichia coli should be taken seriously in trying to investigate the cause of the death of the child.
Thank you. Unless Your Honour wishes me to press that point further.
No, I don't think so.
So coming back to your first report, then we come down to controversies, which is on page 8. Are you following me there? And in relation to controversies, you're saying despite some reluctance to accept that minor infections can trigger SUDI or SIDS, there's a growing body of evidence that infection plays a role, and then you list various research papers to that effect. Can you help me with how it is that minor infections can trigger death?
In the period most affected by sudden infant death syndrome, children have the lowest level of immunoglobulins that would be protective against infection. The material they received from their mother before birth has waned probably to the lowest, and they will have the lowest levels of protective antibodies that they will ever have in their lives. If an infective organism gets into the body, they're going to be dependent on the non-specific immune system, the white cells to go in and deal with this, to kill the organism, to mop up the pieces. And these will then be turned into antibodies. The white cells will then produce antibodies against the organisms that they've dealt with. A minor infection, if say a large number of organisms get in, might trigger a very massive inflammatory response. It might not be a major pathogen like meningococcus. It could be a minor pathogen like Staphylococcus aureus or Escherichia coli. So the damage is done not by the organism itself, but by the body's response to the organism, which is very powerful.
In those circumstances, bearing in mind that you're not a clinician and speaking from your expertise as a researcher, what would you put as the cause of death if a child had a minor infection and was between the age of, say, 2 to 4 months, which is the peak for SIDS?
It would depend on which infective agents were present. If the child had started off with a minor cold and then had a superinfection with organisms in the nose and throat, which is quite likely, the response to these minor organisms could be very much enhanced by the original response of the body to the virus infection.
Bearing in mind your expertise, what would you call the cause of death from a child with a minor infection?
It could depend upon which organ system was going to be affected, because the inflammatory mediators that are produced in response to infection can affect the respiratory tract, the cardiovascular system. They can affect neurological responses. They can affect sleep.
Perhaps if I can ask you to tell me the range of causes depending upon some of the factors you've referred to. And if this is so far outside your expertise, Professor, that you don't feel able to answer it, by all means tell me.
There are a variety of mechanisms that have been proposed
Proposed by whom?
by researchers
By
looking
researchers,
at sudden infant death syndrome. Sleep disruption, sleep apnea, has been one particular aspect that's been looked at. Disruption of the cardiovascular system has been one hypothesis put
Can I
forward.
just stop you there, Professor? So to answer my question, you would refer to various pieces of research
Yes.
that provide a variety of different mechanisms which may trigger death in the circumstances that you've postulated in the first sentence of paragraph 40.
Because we don't know.
No. Is the answer to that yes?
We don't know what actually causes the death in sudden infant death syndrome. But various researchers have proposed different mechanisms by which the physiology of the child could be disrupted.
Thank you.
And responses to infection, the inflammatory responses to infection, can affect all of these.
Thank you. Now, coming over to your conclusions on page 11, you indicate that in paragraph 52 that you agree with the statement of Professor Bayard that the unusual background of this family with many issues of concern does not negate the fact that potentially significant organic illness was present in these children.
Yes.
And you annex Professor Bayard's report, which is Annexure J, and it's some many pages, post the report. In fact, it's probably easy to find it from the end of that document. It's the last few pages at the end of that document, you found it. So if you can turn to the last page, which is page 7. Now, do you see at the top, Professor Bayard indicates that he took into account not just the autopsy findings in isolation, but the occurrence of the 4 deaths within the same family and police concerns, and then he gave the causes of death as undetermined in each, and with reference to what there was evidence that the child suffered from. So with Caleb, it was laryngomalacia. With Patrick, he couldn't exclude epilepsy. Sarah, narrowing of the upper airway, which is the uvula, and Laura, he couldn't exclude myocarditis. Do you understand that they were his conclusions?
Yes.
And in relation to each of those, why there may have been some background of an inflammatory process, that was not the primary reason that he gave. You understand
Might not have
that?
been the primary reason, but it could have been a contributing factor.
Yeah, I understand. I said that there may have been an underlying. You accept that?
Yes.
And then there is the paragraph that you have quoted, which is under conclusions in my view. I'm sorry, your paragraph is the last paragraph that you quoted, the unusual background. And then below that, he indicates that those 3 of those matters are... Could we have the whole page on, please? He indicates that the 3 matters that I've just referred you to may have been coincidental to the deaths, but alternatively may have been causative or contributory, and it can't be clarified. You accept that statement of his as well?
Yes.
Thank you. Now, if I can turn to your second statement, and this is the statement that you prepared at the request of the inquiry. Now, coming to page 3, there's reference at paragraph 5 to cause of death, question mark. You see that?
Yes.
And then the triple risk hypothesis, which you set out. Now, this is the triple risk model that's, I think, been in place since about 1994 and is well regarded as being a model to apply in respect of SIDS or SUDI deaths. That's right?
Yes.
Can we have the triple risk model on the screen? Professor, evidence was given on Monday from Professor Horn, who is a researcher with a particular interest in sleep disorders in children, and Professor Elder, who is a paediatrician, who also has a particular interest in this area. And they gave evidence as to this being the model that's generally applied, and the evidence has been consistent with that. Now, you understand what's on the screen to be the triple risk model?
Yes.
Now, your triple risk hypothesis contains different factors to this, and I'm not sure if it's possible to have both on the screen. Yes? I just need to understand the source of your hypothesis and the reasons for the difference between this model and your, what you call the triple risk hypothesis. So, you have the developmental stage, which is the same, I presume, as the critical period of development, that is the first year of life, and the environmental factors, which refers to the vulnerable infant. Am I right in thinking that? Mm-hmm. And then you have genetics, which probably closely fits with the exogenous stressor on the model. Is that the best way of applying your hypothesis to the model?
I would put male gender under the genetics of the background of the child.
Mm-hmm.
Because we know that males and females have different inflammatory responses.
Now, you can see that you have various factors that don't appear in the triple risk model.
Yes.
In particular, you have under environmental factors of virus infection.
Yes.
Now, is that a factor that you have included in your hypothesis based on your research?
Yes, because we've shown in a model system that pre-infection of the human cells with virus, common virus, will enhance very much the inflammatory response to bacteria. Are you okay?
Well, the only answer I can give you is yes, Professor.
Okay. This has also been tested in a model system with infant rats by Professor Blood Siegfried at Duke University, in which a mild virus infection followed by exposure to a bacterial toxin significantly enhances the lethality compared with the toxin or the virus infection itself.
So is it appropriate to think of your hypothesis as being an overlay with inflammation and microbiology to the forefront of the triple risk model? Is that an appropriate way to view yours?
Yes, it's applying the triple risk model to looking at the effects of inflammation and infection in triggering a death.
Which is your specialty, obviously.
Yes.
Thank you. Now, the other matters referred to in answer to the question of advances in diagnosis and mechanisms are primarily matters that can be either resolved or contribute to an understanding by way of the genetic testing that's being undertaken by the inquiry.
I think that's going to be the major step that
Thank
needs
you.
to be assessed, and it's going to provide more information as to the cause of the death of these children.
Thank you. Now, just turning to your third report, this is the supplementary report relating to Caleb. And that effectively adds little to what you've already said in relation to Caleb. Is that fair?
And the question was, what was the source of the eosinophilic exudate?
And we just don't know, do we?
And because there's no microbiology report, we can't say anything more about that.
Thank you. Thank you for that, Professor. Professor Clancy, can I turn to you?
Yes.
Professor, are you currently retired?
No.
What are you doing these days?
Sorry, my wife would like me to be.
I'm sure that's right. What are you doing?
I do a number of things.
Not so sure that that's right.
No. Well, perhaps His Honour might be in a slightly different position, Professor, but perhaps we'll deal with you first.
I still do a clinic once a week on Thursdays. I'm involved in a number of research programs looking at the mucosa of humans and their relationship to bacteria and their responses through working with an ex-PhD student of mine. I seem to get involved in quite a wide range of medical issues, some of which I wished I wasn't.
Well, you need a bit more discipline, I suspect.
Yeah.
Saying no. Looking at your CV, which you provided as Annexure B to the statement, you say that you initially trained in gastroenterology but more recently seen as a clinical immunologist.
Oh.
That's unusual terminology to my mind.
When I trained in gastroenterology, there was no formal program. I was always interested in immunology from student days, but there was no pathway. I became one of the three people who established clinical immunology as a discipline in Australia, and I was the first clinical immunologist at Prince Alfred Hospital. Then I took the Foundation Chair of Pathology in Newcastle. So when I say people see me, they do see me as a clinical immunologist, although my primary training for those reasons was in gastroenterology.
Thank you. Now, I think from your CV, you mainly see adult patients, is that right?
I do now. As a clinical immunologist, I've seen children. When I was at Prince Alfred Hospital, we provided the service for the Children's Hospital in immunology. All my working life, I've seen children if people refer them to me. But predominantly now, I'm seeing people 15 or over in the last 2 or 3 years.
You've got no particular paediatric training, I take it?
No more or less than most general physicians of my age.
Thank you. Now, you have attached to your report, if I may say, a lengthy document that is headed, this is attachment A, Submission for Degree of Doctor of Science. Now, I confess to not having read it all, Professor.
Oh.
I know, I apologise for that. Can you perhaps explain to us what the document is?
The document essentially covers my research career as a mucosal immunologist, which is what I am, and it examines numerous circumstances where different mucosal surfaces in different patients at different ages have met with different pathogens, different bacteria, viruses, and the way in which the immune response has reacted in those circumstances and how the interaction between the microbe and the response have led to outcomes, clinical outcomes.
Are we to assume that some of the material contained in this annexure has been published in various forms?
It's all been published.
Thank you.
With very, very few exceptions, which wouldn't be relevant to here.
Thank you. Now, you were asked to provide a report by those representing Ms Folbigg.
That's correct.
And we have the letter that you were given seeking the report, and I don't know if we can have it up on the screen. And the second page. This is a list of the documents you were provided with.
Yes, I was provided with most. There were one or two there I'm not sure that I actually saw. I don't think I saw the handwritten notes of Dr. Colley. There were one or two but most of those I did see.
Professor Cordner's report's not included in that list?
I was certainly shown Professor Cordner's report.
Did you read Professor Cordner's?
Absolutely, yes.
Are there any other reports that or documents you remember getting that are not listed in that list?
No, I saw Professor Duflas, Professor Cordner. Yes, there's... Oh, yes, I saw the only other additional ones over and above the autopsy reports, which I obviously saw, was the final microbiology reports, which I only got a couple of days ago.
Right, thank you. So you didn't take them into account when you wrote your report, or you did?
I wrote a supplementary report.
All right, well, coming to your report, you refer in your report and the annexure I've just referred to a study that you were involved in, a prospective study of 260 babies that you followed over a period of 21 years, correlating clinical events with parameters of mucosal immune competence. Now, during the course of that study, one baby died, and that cause of death was attributed, presumably by you, to sudden infant death syndrome?
That's partly correct. I set up a study over 21 years trying to get answers to questions that had been asked but not answered, and that is this relationship between microbes and the immune response. We had one of those children die from sudden infant death syndrome. I didn't know about this till 1 year. I had nothing to do with the diagnosis, the clinical care, or the pathology report on that particular patient. I found out only 12 minutes later, and then I went back, and what in essence we had was really the missing link in SIDS, because if you notice, and I was interested in a lot of the points you made in the previous questions, that pretty much all of that is based on fairly old data, ideas that have been around for quite some time. The problem was you do not do studies prospectively on SIDS because apparently healthy child suddenly dies. And so we had the world's first and only carefully done study where we could really identify changes that were going on that would not have been known by the clinician at the time. We follow that up, as you would have noticed, in a very careful, intensive study between two major centres in Perth and Newcastle, where we took near-miss SIDS or ALTIs, the acute life-threatening event children, and at the time of their admission to hospital, we were able to examine them with the knowledge we had from the young baby that died from SIDS to see if the same changes were present, which essentially they were.
So your research began with the one baby, and then you extended it to the 20 cases of ALTIs, as you've described in your report.
That's correct.
When you dealt with the ALTIs, did any of those children ultimately die where the cause of death was attributed to SIDS?
We only saw those children at the time they were in hospital, so we saw them over a 2-week period. I have no information as to what happened to those children after 2 weeks.
The inquiry heard from Professor Horn do you know Professor Horn?
No, I don't.
I think you were given her report according to the documents.
I don't think I saw that.
She wrote in her report about the latest research in respect of ALTIs and SIDS, and her conclusion was that there was no longer considered to be a connection between ALTIs and SIDS. Are you aware of that recent research?
No, I'm not.
Assuming that research is valid, and there hasn't been any evidence to the contrary, but assuming that's been valid, then your findings in relation to the 20 cases of ALTIs might have less significance in terms of SIDS. Do you accept that?
No, I wouldn't accept that. I wouldn't accept it because I haven't seen this data of Dr. Horn's. I'm surprised by it because if you go back and look at the data of the Alties and the SIDS patients, the parallelism is quite remarkable. And it's quite different. It was a very carefully done study with controls of other infected children with the main virus that was involved in the Altie cases and probably most of the SIDS, which is respiratory syncytial disease virus. And the controls were markedly different to those in the Altie cases and which were nearly identical to those in the SIDS. So, it's certainly my belief that there is a very close relationship, at least with most of the Alties. Of course, these are complex and multi-cause issues, but most of them, I think it was 75% of the Alties.
But you don't know whether any of the 20 cases you considered ended up dying from SIDS?
Actually, when I wrote 20, I went back and it's 26. But no, I don't. There's no way I could know that because I only saw them over a 2-week period.
Perhaps if I can show you what Professor Horn had to say, and if we can have her report up on the screen. It's on page 5, and perhaps if we could just have the first page up first. This was a document that, according to the letter of instructions, was provided to you. Professor, just have a look at the first page and see.
Yeah, no, I didn't. I
Didn't read it? Perhaps then if we can turn to page 5, unless you want to understand Professor Horn's expertise beforehand. You see that she has a PhD as well as a Doctor of Science. And perhaps if you've read sufficiently of her background, we could turn to page.
Well,
I'm in your hand.
I'm just trying. Sorry, I'm slow.
No, please, I don't mean to
So
rush
I'm just looking at the background now, am I?
for your information.
Yep. I'm not sure what... is she a clinician or a...
No, she's not a clinician.
Okay. Okay.
And then if we can turn to page 5. So I don't expect you...
Look, I really need to sit down and go through this carefully before I could give a measured opinion.
Certainly. Well, as I've said, the evidence that is before the inquiry is that that connection is no longer a valid one. In the event that...
Can I just ask you, I'm assuming she is looking at children who have Alties and then subsequently may have SIDS, is that correct?
Well, it's the relationship between an Altie and SIDS. So
Yes, but they would have to be looking at patients and saying, this person's had an Altie, have they gone on to get SIDS? Is that how she did it?
Well, let's have a look at what she said. It's on the screen in front of you. Because
that's a very complicated situation.
I've no doubt it is. I've no doubt it is, but this woman has spent, I think, most of her life dealing with these sorts of matters. But nevertheless, I don't doubt it's complicated at all. In the 70s, it was thought that Alties were precursors of SIDS, and they were referred to as near-miss or SIDS events. 80s and 90s, there were various studies carried out, and she then refers to various studies in relation to sleep and breathing and reflux.
These were all theories that came and basically went. I think part of the problem is that they didn't have any hard data as to exactly what was going on in SIDS or Alties to really make those decisions. I think my group actually provided that.
I think her work is perhaps more recent, but...
That doesn't make it better.
Let's not engage in a debate about it, other than to indicate that that's the evidence before the inquiry, and to invite you, if you wish to do so, Professor, to provide a response, if you wish, to that work of Professor
Well, I'd be very happy to if I had the chance to read it and see what she's talking about.
No, I'm not meaning now at all, Professor. I'm meaning subsequent to
Oh,
this.
yes, I'd be happy to.
Excuse me. Now, if I can then turn to, excuse me. If I can then turn to the rest of your report at page 2. You refer to having read the autopsy reports and
That's
agreeing to the diagnosis made by the attending pathologist and the consultants, and agreed by consultants in each of Caleb and Sarah.
Correct.
And then you agree with Professor Cordner and de Fleu in the case of Laura, and effectively in the case of Patrick.
That's correct.
So that assumes that you read Professor Cordner's report, notwithstanding
That's correct.
it's not listed on the document provided. And you then continue down at paragraph 18 to the conclusion that you see no evidence that any child had been mistreated or any evidence of external evidence or internal evidence of suffocating or alternate cause of death. Now, can I suggest to you, Professor, that the material you were provided is of a limited nature, given the available material to the inquiry and from the trial? There has been many reports prepared by a variety of people, forensic pathologists, paediatricians and the like, and there has been evidence given by those as well as treating doctors, including paediatricians, neurologists and the like, each of whom has formed a view and often given sworn and tested evidence in respect of it, which you have not had the opportunity to consider. So in light of that, I invite you, in relation to paragraph 18, including the last sentence, which I haven't read, which is any conviction of Kathleen Folbigg based on medical grounds in your opinion would be unsafe, I invite you to consider that conclusion based on, as I've indicated, the limited nature of the material you've had available. What do you say to that?
I understand your question, but I'm not certain what additional information you would want me to have to change that view, because I've examined, surely we're looking at evidence from postmortems, and I've read every word of all the postmortems. I've seen the opinions of experienced people, and it makes what I've said here, I think, unless you can tell me there's information that I haven't got that would change that opinion, which I can't understand what it would be, that would not be helpful.
There is evidence that you have of different people's opinions from that of Professor Cordner and de Fleu, and you've read their reports.
Yes, that's true.
You haven't read the reports or read the evidence of others who have had different views, who are nevertheless well qualified, eminent in their areas, and have read all of the medical records.
But I've read the pathology reports. I'm wondering what information you have that I don't have.
Well, the information is, as I've said, the evidence that these people have given before the trial, the reports they have written based on reading the medical reports of these children, in addition to, but not limited to, the autopsy reports.
Okay.
If you consider that additional material would not be of assistance to you given what you've had, and you don't wish to revisit your conclusion, that's a matter for you. I'm giving you the opportunity to reflect upon it based on the additional evidence, Professor.
Okay. I'm struggling to understand how that additional evidence would change my view, but I'd be very happy to look at that and then change my view if I thought that it should.
Can the inquiry take it that the view you've expressed in that paragraph and subsequent paragraphs is based on the material you read?
Exactly.
Thank you. I have nothing further on.
Thank you.
Oh, Your Honour, I'm told I haven't tendered Professor Clancy's report. Am I? there's two reports. The first one, together with the letter of instruction, dated the 13th of March 2019, and the supplementary report, dated the 17th of March 2019.
Tendering there was one exhibit,
I'm happy to, Your Honour.
Exhibit W.
Your Honour, just in relation to the tender of those two reports, I suspect that the Professor's address in paragraph 2 is his residential address, and to that extent, if we could arrange to have that redacted.
It's also on the letter of instruction.
Well, the address, his home address should be redacted.
Thank you, Your Honour.
Yes.
It-
Does anyone want to go before cross-examination? No? Do you have any cross-examination,
I have no questions for either witness.
Ms Richardson? Okay. Yes. Thank you, Mr Morris.
Thank you, Your Honour. Professor Blackwell, I'll direct my questions to you in the first instance. Do I take it from your evidence this morning that you only spoke with the lawyer at the Legal Aid Commission representing Ms Folbigg after the trial had concluded?
That's correct, yes.
You hadn't spoken to him or anybody else on behalf of the Ms Folbigg's legal representatives before the trial?
No.
And certainly you hadn't spoken to them at any time after you'd spoken to Detective Senior Constable Ryan, is that correct? Now, as to paragraph 16 of your first report, you make mention that it is, just excuse me a moment, Your Honour. Is it page, paragraph 16? I see. You recommend, in relation to the cerebrospinal fluid and the examination of the inflammatory responses in the cerebrospinal fluid, are those processes to which you refer in paragraph 16 of your first report, were they available as at 2003?
I was asked to write the report in 2004 by Mr. Christenthal after the trial.
No, I understand, but as to your suggestion about the retesting of the cerebrospinal fluid,
Yes?
was the technology to retest available in 2003? No, it wasn't.
Yeah.
And you make mention that there are new rapid methods for screening viral DNA. Do we take it from that those methods have developed since 2003?
The clinical microbiology detection systems are developing rapidly all the time, and certainly since 2003, we would be much more likely to find the virus if the virus is there.
I see. And is it possible that because of the effluxion of time and the effect on the samples, that one might obtain negative results?
It depends on how the samples have been stored. If they've been frozen, you might have a better chance of finding them. If you needed to rely on formalin-fixed samples, I couldn't answer that question. You'd have to speak to somebody who is an expert in clinical microbiology.
I see. But the point is that if that testing were to take place, it might be impossible to actually identify the relevant inflammatory responses because of deterioration in the samples?
If probably even frozen, you won't be able to detect any of the inflammatory responses because these are very short-lived, quick-acting molecules. You might be able to find the viral DNA by the new automated molecular methods.
But if you were unable to find the viral DNA, that might be a result of deterioration in the samples rather than the presence or absence at the time the sample was taken.
You can't say, testing a 20-year-old sample, I don't think if you have a negative, that you could say that was truly a negative.
In other words, there's a risk of false negatives.
There's
Is
a
that?
risk of a false negative.
Now, in relation to your evidence today about the swollen uvula and your opinion on page 3, and your earlier opinion in your report to the legal aid solicitor that you did not think that the swollen uvula, and I'll take you to, it's your second, it's the annexure to your report in which you say, and I'll read it to you to speed things up, swollen uvula, there is little evidence that the swollen uvula in Sarah was associated with her death. Was that based upon information that you had received at the trial, and if so, what was that information?
I thought that some of the opinion that was being put forward was that it was the physical obstruction of the air passage by the swollen uvula. But I don't think that was probably a cause of death. I think the swollen uvula reflected the inflammatory responses that were going on to the bacteria that were isolated from Sarah.
In regard to forming your opinion, did you take into account the evidence of Professor Hilton at trial about the swollen uvula?
I read Professor Hilton's comments at the trial. In any of these deaths, there's no single cause. You can't say that it was the swollen uvula, it was a high level of IL-6, it was the presence of bacteria in the throat. This is a multifactorial series of events leading to the death of the child. I don't think you can put your finger on one particular factor and say that's what caused the death.
Now, in relation to some questions from a friend about studies by Professor Morris and other studies by Weber, is it the case that those studies were based on a re-examination of forensic pathology material and that they had identified that in bacteria which had previously been thought by forensic pathologists to be contaminants had, in fact, after review by microbiologists, determined that they were pathogenic in the bodies of the deceased?
They may have contributed to this series of reactions in the body leading to the death of the child. Again, this is a multifactorial thing.
Professor Blackwell, could you listen to my question? The studies that were performed that you referred to by Professor Morris on the one hand and Weber on the other were studies of forensic pathology findings where forensic pathologists had previously thought that the bacterium identified was contaminant, and after microbiological assessment, it had been determined that those bacteria identified on pathology were in fact pathogenic, or no, they weren't contaminants.
They were more prevalent amongst the children who died suddenly and unexpectedly, compared with children who had died suddenly and unexpectedly with no infective cause detected.
Professor, the studies you referred to were a review of forensic pathologists' opinions about whether the bacteria were contaminants or not, weren't they?
Yes.
And after microbiological assessment by Professor Morris, he identified that the forensic pathologists were wrong in a certain number of cases, correct?
That they had not taken the detection of a pathogen seriously.
Well, that in fact the bacterium was not merely contaminant, but in fact was present, correct?
Most likely contributing to the death of the individual.
Thank you. And so that determination by a microbiologist demonstrated that the forensic pathologists who had identified the bacterium as contaminant had got it wrong, correct?
Sorry,
If we can
I'm sorry to
step back
stand you,
a bit.
excuse me.
There are-
Professor Blackwell, please.
Okay.
It's not clear to me, Your Honour, and I'm not sure if it's clear to the witness, whether or not my friend's questions are solely related to Professor Morris's 2006 literature review or something else.
Well, Professor Blackwell, you raised the question, is the question of whether, in your opinion, is the question about whether the existence of a bacterium within a body, the identification of a bacterium within a body is a contaminant or not, is that really a question for forensic pathology or microbiology?
It's a question for both. And the question also needs to include where was the organism isolated. If it's in a normally sterile site, like the blood or the spleen or the lungs, the organism has to be taken seriously as a potential source of death.
Why is that?
Something like Streptococcus pneumonia or Neisseria meningitidis in the blood, there would be no question about this. The question comes to what are referred to by Weber as the category 2 pathogens, things like Escherichia coli that are a normal part of your gut flora. If they get into the bloodstream, they can cause septicemia. Staphylococcus aureus can be a normal part of the flora of your nose and throat. If it gets into your blood, it can cause problems. It can produce toxins that are highly lethal, like toxic shock syndrome toxin. What you need to do is to look at where the sample was taken, under what conditions the sample were taken. Were they just sort of wheaked out and put into the jar, or were they collected aseptically? So you have reduced the probability of contamination as much as possible.
And tell me this, is the time between death and collection relevant, and if so, why?
There have been a number of, I'd say, categories of explanations as to why you would find microorganisms in the blood after death. One is called agonal events, that during the cause of death or resuscitation, that bacteria that are normally on the surface of the nose or the throat or the respiratory tract are pushed into the bloodstream. That doesn't seem to hold up, following Professor Morris's review and the work by Professor Weber and his colleagues. The other is that as the body decomposes, that organisms are released by the dying, the loss of integrity of the mucosal surfaces. According to Professor Morris, if the body is kept at 4 degrees, this is not a problem. The major problem is contamination by the person taking the sample.
Okay. So, are there tests available that tend to confirm or disprove whether the presence of bacterium found at autopsy were pathogenic or simply contaminant? And if so, what are those tests? How would you look at that?
I think you have to look at the clinical picture. In the case of Patrick, he was very ill the night before he died. There were 2 organisms found in his blood. One was E. coli and 2 species of Enterococcus. According to a very extensive study in 1997, if you find E. coli in the blood of a patient, this is most likely to be a significant finding in 90 to 99% of instances. If you find Enterococcus in the blood of an individual, it's about 70% probability that this is a true finding, that this organism is causing problems. Patrick had fever and vomiting and was sweating the night before he died. This sounds to me like an infection.
Are there any other tests that can be done? I was specifically asking about tests to be done rather than clinical picture. Are there any tests that can be done that determines whether in the deceased there was an immune response which may determine whether the presence was of the bacterium in the blood was incidental or contaminant or actually pathogenic at the time?
It takes about a week for an immune response to develop. So if you found antibodies, say, to the pathogen in the blood, then the person must have been exposed to it at least a week beforehand. I can't think of any specific tests of the type that you're asking for.
What about this? We've heard discussion about cytokines and so on.
Those are very short-lived. You have to take the sample very quickly. Detection of these has improved enormously. There are now automated tests for it. This wouldn't be useful on stored material these days.
But these days, the technology wasn't available at the time of the death of these children, but these days that would be a test which...
It's not a standard test for, I would say, probably forensic pathology, because it would be deemed too expensive. And the idea that very powerful inflammatory responses could contribute to these deaths is not widely accepted amongst the forensic pathologists, all the forensic pathologists. The Norwegians look for these things, but I can't think of any other country where they actually actively look for these.
Okay. But it's that sort of test which would determine, which would provide you with evidence as to whether, in fact, it was contaminant or, in fact, a pathogenic.
Some
event.
organisms you would probably eliminate as being pathogenic, unless the individual was compromised. If you found another species of Staphylococcus aureus, that would usually be a skin contaminant to be picked up when the blood sample was taken. If the person from whom the blood sample was taken had a urinary catheter in, then you would have to take that more seriously. Just finding an organism doesn't tell you that it's causing pathology. You have to look at the whole picture in order to figure out what's actually going on.
Okay. And when we look at the whole picture, you're looking for clinical signs of infection, correct?
Yes?
And you're looking for signs of infection in organs at autopsy, is that right?
Yes.
And anything else you're looking for?
In the past, we've looked for the toxins of Staph aureus, and we found them in over 50% of babies from 5 different countries. This isn't a standard test. This is a research tool. Professor Hilton sent us a series from his collection, and we found Staph aureus toxins in over half of the babies, the SIDS babies, that he had examined. We found the same proportion in children from France, from Hungary, and about 65% among the children from Germany. But this isn't a standard test. But we certainly know that these toxins can be lethal. Toxic shock syndrome, food poisoning.
So those samples that you received from all those countries were samples from children who died of SIDS?
Yes. And Professor Hilton sent some samples from children who had died of other causes. And we only found the toxin in 2 of them. One child had had cystic fibrosis, and you would expect this because children's cystic fibrosis are colonized early with Staphylococcus. And another child who'd been in hospital for a very long time.
And what was the sample of children that he gave you who had not been diagnosed with SIDS?
Without SIDS, there was a very low proportion of them, and finding the toxin was actually explainable from their medical conditions. The SIDS children, over half of them had the toxin in their tissues.
Okay. Now, in evidence to my learned friend this morning, you said that these children did not have the classical immunodeficiencies. All right?
Yes.
Just explain to His Honour what is meant by the classical immunodeficiencies.
Some children are born without the ability to produce antibodies, the components in the blood that help to mop up bacteria or viruses or toxins. These are produced in response to exposure of the child to the organisms in the environment, and they're also produced in response to immunization. It's these antibodies that protect the children from childhood diseases. And there was no evidence that I could see in any of the reports that these children had a classical immunodeficiency. Professor Clancy would probably be better to ask about the various categories of these deficiencies.
But I don't think we need to talk about the various categories of them. What you're saying is that on your review, these children did not have any pre-existing immunodeficiency which would have explained the death?
No, I don't think so.
No, okay. And in the moving on, can I take it to paragraph 46 of your first report? I take it from the first sentence in 46 with respect to Patrick, the hypothesis that there was a viral encephalitis is not supported by any microbiological or immunological evidence.
Yeah. Virus wasn't detected and no immune response to any virus was detected.
So is His Honour to understand that even though they targeted the herpes simplex virus and they found no sign of that, that the CSF tests and blood tests and so forth taken at the hospital on the 18th of October and in the days following essentially excluded an encephalitis? But that would leave open an undiagnosed encephalopathy.
Yes.
And in relation to paragraph 48, is the fact, paragraph 48 of your first statement, is the fact that you've highlighted the word profuse. In the lungs, Sarah had profuse number of coliforms. Have you emphasised that for a reason, and if so, why?
Because there are very few infectious diseases in which one or two organisms is likely to cause disease. One is syphilis, the other is typhoid fever. For most infections, you have to have a large number of the organisms present to overwhelm the body's defenses. So it's a numbers game. The higher the inoculum of the infectious agent, the more likely the person or the individual or the animal is to develop disease.
I see. And so was the existence of profuse numbers of coliforms an important factor when forming your opinion?
Yes.
Your Honour, note the time.
How much longer will be?
It might be another 20 minutes, Your Honour.
Well, I think we should press on.
Okay.
Oh, Your Honour, I have a few questions following.
Oh, okay. Well, we'll adjourn for a quarter of an hour. Yes, Mr. Morris.
Thank you, Your Honour. Professor Blackwell, just before the morning tea adjournment, we were talking about the absence of classical immunodeficiencies in these children. And I want to take you to paragraph 17 of your report, please. Now, just read that paragraph to yourself and let me know when you've finished reading it.
Yes?
You start the paragraph stating that there's recent evidence for associations between SIDS and SUDEP, and that you then go on to say that the hypothesis proposed is that death due to seizures initiates pathogenic signalling between the brain and heart, resulting in lethal cardiac arrhythmias. Now, just in relation, well, for the benefit of this inquiry, could you just explain the hypothesis about how mild infection in a child may give rise to an unexpected death?
Right. There are a number of parallels between susceptibility to infection and the risk factors for SIDS. The first is age, particularly the age range in which the peak of SIDS classically occurred, the 2 to 4 month age range, when they have the least amount of antibody they will ever have in their entire lives. The second is the presence of older siblings. The older siblings go to play groups or nurseries or schools and bring home whatever their colleagues have to pass on to the baby. Exposure to cigarette smoke enhances susceptibility to infection in a number of ways. First of all, smokers are more likely to have virus infections. And the components in cigarette smoke are sticky, and so it's like flypaper for a number of organisms, and they just stick in greater numbers to this tarry substance on the buccal cells of the individual. Smoking will also reduce the anti-inflammatory responses, which help to damp down the damage that's done in response to a mild infection. If you look at the overall picture, it's like a jigsaw puzzle. You suggest that the hypothesis is that the factors that make a child more susceptible to infection are those that are found amongst the risk factors for SIDS. And what we've done is to test a number of these to see how the risk factors would enhance or exacerbate infection. And the latest publication was a review I did in 2015, in which we tried to put these various pieces of the puzzle together. The hypothesis includes not just infection, invasive infection, or mucosal infections, but also the production of toxins, whether by the E. coli or the Staph aureus, that can cross the mucosal barrier and induce inflammatory responses in the child. And so far, the studies that my group and other people have done have found that things like the prone sleeping position, which was a major factor in relation to sudden infant death, and when people started turning babies over the incidence disappeared. Professor Morris and his colleagues took nose swabs from babies from birth to about probably 10 or 12 months. At the period when the baby started rolling over on its front, the secretions in the nose would pool in the nose overnight, and you got not only more bacteria, but a greater variety of bacteria. The prone sleeping position is also important because it raises the temperature of the nose. Normally, the temperature of the nose is well below 37 degrees because of the passage of air back and forth. My colleague in ear, nose, and throat department measured the temperature of noses in the noses of children lying on their back and lying on their tummies. And there was a significant rise in the temperature in the nose of these children. Now, this is important because the toxins that are produced by the Staphylococcus are only produced between 37 and 40 degrees. And in 5 of these children, when they were lying on their tummies, the temperature in the nose rose to 37 degrees or over. So, while the prone position has been linked to things like sleeping problems or cardiac arrhythmias and things, there's a simple explanation in that you're going to have a pool of microorganisms in the nose of a baby lying on its tummy, and the temperature may reach the point that the toxins can be induced. It's looking not at just one factor or one hypothesis, but trying to fit these pieces of the puzzle together. And sometimes the pieces aren't very obvious, and you want to take the scissors and cut the piece to fit in properly, but you can't do that. You have to play fair.
And the toxins have what effect on the physiology of the child? Just explain to His Honour.
They can cause a massive inflammatory response, not just in children, but also in adults. Toxic shock syndrome was a big problem because tampons were infected with Staph aureus, and young women were developing toxic shock syndrome, and some were dying. And Professor Morris had to investigate a case of one young woman who just sat up in bed one morning and dropped dead because she had a massive, not infection, but toxicity due to the toxic shock syndrome organism, which is found in the tampon.
And does the toxin produced by the inflammatory response,
The toxin induces the inflammatory response.
right?
And the inflammatory response can affect all of the physiological systems in the body.
Just
The heart, breathing, and the neural responses. It's a very powerful toxin.
when you say the neural responses, are you talking about some sort of neurotransmitter disturbance?
This has been investigated by Professor Kenny and her group in Boston. And they are the people who have identified changes in receptors of neurotransmitters, increased or decreased levels of neurotransmitters. Again, it's a very complicated series of interactions, and you would really need a neurophysiologist to explain all of these problems. But these interactions can be affected by inflammation.
And the inflammation having a bacterium as the cause. Is that what you're saying?
The bacteria or their toxins switch on these responses from the white cells in the body.
Now, are you familiar with Professor Bayard's book?
Yes?
Sudden infant death and sudden infant and early childhood death. Your Honour, might we have Exhibit D up, and it's Volume 2, page 689, Your Honour.
689.
689.
No.
Are you familiar with this chapter by Professor Opdahl? And is there anything inconsistent with your view that appears in this chapter, or is it largely consistent?
It's quite consistent. The group in Norway have been looking at the role of infection and inflammation for a number of years. And they were the first people to identify one of these components, interleukin-6, in the spinal fluid of children who died of SIDS, and compared those with children who had died of infectious causes and those who had died of other causes. And the IL-6 levels are definitely raised in the children who had died of SIDS.
Now, I'd like to take you to page 701 of that chapter. And there we have, my friend showed you fatal triangles before, and she asked you certain questions about that proposed by Professor Horn. I want to suggest that this is another that appears in Professor Bayard's book. Do you have any comment to make on the integers that make up this particular concept of the fatal triangle in SIDS?
To the developmental stage, I would also add the maturation of the nighttime body temperature cycle, which colleagues in Leicester have shown are associated with other hormonal changes in babies. During the day, the hormone cortisol is quite steady, and at night it's fairly steady. But when the baby develops the lower nighttime body temperature that is associated with maturation and development, the nighttime cortisol levels drop like a stone. And one of the members of my group assessed the effect of these levels, daytime levels, nighttime levels before the switch of this important developmental stage, and the nighttime levels after the switch. And what she found was that the daytime levels were perfectly capable of damping down an inflammatory response. And so were the levels at night before this developmental switch. But once the switch occurred, there was this period where the very low levels of cortisol were not able to damp down the inflammatory responses, and in fact they enhanced it. So this nighttime switch takes place during the period when many infants, those of European extraction, are susceptible to infection. They are unable to protect themselves because they haven't completed their immunizations, and the maternal antibody is at its lowest. If the inflammatory response is switched on at night, the cortisol levels are not sufficient to damp them down and may actually enhance them.
Is there something you need to know about that?
Yes, Your Honour, it's important. It is important, and I'll tidy it up. It's my last point.
If you look at the ethnicity factor,
I'm sorry, the ethnicity factor I don't need to know about, Your Honour.
Right.
I don't need to know about...
okay, but it is important because once this switch occurs much later in Asian children, for reasons we don't yet understand, by the time this switch occurs, they have been immunized more fully than they have lower levels of maternal smoking. They have more people around to keep them awake if they drop off or try to roll over face down onto a sofa. So again, this is multifactorial, and the developmental stage of the child is extremely important, not just for the immune system and the central nervous system, but for control of various physiological mechanisms.
And just in relation to cortisol, the cortisol level affects the inflammation response, does it?
Yes.
And for instance, if an adult has an immune response difficulty because of dropping cortisol levels, they'll be given something like prednisone or prednisolone to try and bolster the cortisol levels to fight the inflammation. Is that correct?
I would address that to Professor Clancy, who is much more familiar with adult.
Okay, well, but cortisol is one of the issue of...
Reduces inflammatory responses.
It reduces inflammatory responses.
But in the low levels that are present in babies following this physiological switch, they can actually enhance inflammatory responses.
And these matters that we've been talking about, these scientific observations that have been made about things like nasal temperature, cortisol response, etc., together with the other matters which you address in your report, these pieces of scientific evidence seem to have supported the basic hypothesis that infection has a strong connection with the incidence of SIDS. Is that correct?
I would say in a significant proportion of children, infection may be contributing to the physiological events that lead to death.
Now, Professor Clancy, just in relation to the cortisol level and the effect of cortisol on the inflammation response and so forth, would you just...
Yes, I mean, that's certainly so. I think it's probably a lot more relevant in a maturing young infant than it is in older children and adults, where the levels do vary, but have probably less significant effect on inflammatory responses under a much higher... They seem to become more tolerant to those changes, but the younger child, the infant, is more susceptible.
And is there anything that the further information that Professor Blackwell has given us this morning, is there anything that you wish to correct or contradict with respect to her analysis of things?
I'd just like to make maybe two brief comments. One is on the issue of contamination, which Professor Blackwell's commented on and I think added to. It's contamination is seen by forensic pathologists probably intuitively to an extent, and much more so than has been shown when standard postmortems have been looked at, and where the contamination rate is less than 10%. The second point, minor infections are incredibly important in SIDS in the sense that they appear, and certainly in our studies, they appear to trigger at a critical stage of changeover of the mucosal immune response. They trigger a bizarre immune response which is seen locally in the local tissues. We found it in saliva. Other people have measured these antibody responses in cells, which after death. So they play a critical role at a time when the mucosa is unable to cope. And whenever that happens in any circumstance in humans, bacteria appear, and particularly in younger people, staph and some of the streptococci, which has appeared in at least one of these cases. And then you get that series of problems as a result of that. In younger kids. It can be even small amounts of toxins. In older people, it can excite a different type of inflammatory response. I just wanted to make those two comments.
Thank you. And in relation to the discussion that you had with my learned friend with respect to the ALTI study and the extent to which ALTI patients who've had an ALTI then go on to progress to SIDS, and the study of Professor Horn, you've got the capacity to examine that material of Professor Horn, and if you come to some significant agreement, prepare a short report addressing your studies. Is that correct?
Yes, I'd be very happy. The comment I wanted to make was that the data that I talked about and presented was crystal clear objective data showing very similar, bizarre and different immunological responses that were identical and only found in SIDS and ALTIs, whereas if you're looking later, you're looking for a whole variety of things that would change. People who have an ALTI in a child follow that child obsessively. They ensure that there's no smoke exposure, there's no, all of the various things because they're dead scared. And the second issue is that these kids are moving into a different age range after their ALTI. So, it's a very complicated thing to look at clinically, whereas if you look at the time and see the mechanism is exactly the same as you find certainly in the outpatient with SIDS, which is the only one studied.
Thank you. Your Honour, I don't know how I went on the time estimate, but I have no further questions.
I think you did quite well, Mr. Morris.
Thank you, Your Honour.
You're very generous, Your Honour. Professor Blackwell, paragraph 38 and 39 of your first report, this is in relation to the coliforms. You refer to the 1992 publication of Gilbert.
Yes.
Now, I'm not sure if we have that available on the screen, do we? We do. I want to take you to the table from which I believe you obtained your figure. You see there in relation to Sarah, you halfway down, the report indicated a finding of coliforms in an infant conferred an increased relative risk for SIDS of 29. And you refer to that also in relation to Laura. Now, this article, we know it's a 1992 article, and the conclusion of the article, which will be coming up soon, I'll read it to you while it comes up. Yes, if we can just highlight the abstract, thank you. The viral infection was not a major risk as long as babies were lightly wrapped. In heavily wrapped babies, the presence of a viral infection greatly increased the risk of sudden infant death. You would agree with that?
And so this is the abstract?
It's the last paragraph.
Yes.
Coming then over to page 174, table 3 sets out the potential bacterial pathogens, and you see under coliforms, if one moves along to the third column, 29 is the odds ratio.
Yes.
And that's where you obtained the 29 from.
Yes.
And then if we come down to the next table, table 4, in relation to coliforms, 37, that is the most, were found in the tracheal aspirate. Do you see that?
Yes.
And in relation to the lung, we have significantly less at 14,
Yes.
and the spleen, we have 3.
Yes.
Now, you'll be aware from the material you've read that in relation to Sarah, her coliforms were in the lung, as with Laura, and in relation to Laura alone, hers was in the spleen. Do you accept that?
Yes.
Isn't it the case, therefore, that the odds ratio of 29 is not relevant to either Sarah or Laura?
I think finding coliforms anywhere where they shouldn't be in an infant indicates that the child is unwell.
That may well be the case, Professor Blackwell, but the 29 odds ratio you referred to is based primarily on a finding in locations other than Sarah and Laura had their coliforms. Isn't that right?
Mucosal surfaces.
No, Professor Blackwell. Thank you for providing an explanation, but I'm asking you whether your figure of 29 was based primarily on findings of coliforms in places other than where Sarah and Laura had them. Is that right or
Mucosal
not?
surface is a mucosal surface.
No. Just answer the question. Am I right or wrong?
You're correct.
Thank you.
But what I'm saying is that it's not correct to categorise mucosal surfaces.
Thank
If you find these organisms in a child where it shouldn't be, the child is probably ill.
Thank you, Professor. I needed you to explain the 29 figure, and you have done that. Thank you very much. I want to also refer you to the Morris paper, which is the 2006 Morris paper, and I think we have that as well. You gave some evidence about this earlier. On page 8, the take-home messages are very helpfully boxed. The final take-home message is a pure growth of a pathogen in a blood or cerebrospinal fluid should be regarded as a possible contributing factor to death at all ages, but corroborative evidence should be sought using a range of techniques. I take it you'd accept that as a take-home message from that article?
I'm sorry, I didn't hear what you were saying.
I beg your pardon. Do you see the 5th dot point?
Yes.
You would accept that that is an appropriate conclusion one can draw from Morris's 2006 article?
Yes, the main artefact is contamination, but when you have what is considered to be a potential pathogen, you have to take it seriously. If this were the contamination of Propianobacterium or the Staphylococcus that lives on the skin, I would be willing to consider that as contamination, but not something like E. coli or Staph aureus.
There's no suggestion in this 5th dot point that the author isn't taking it seriously. He's providing an opinion that it's a possible contributing factor and you need to look for other evidence. That's not inconsistent with taking it seriously, is it?
Yes, the main post-mortem artefact is contamination. It's not things that had previously been suggested, like agonal incidents or the transfer across membranes
Let me
after
just stop
death.
you there, Professor Blackwell. Thank you for your explanation, and you've had opportunities of giving that explanation before. Do you accept what the author of this paper, which you rely upon in a number of respects, has said in that 5th dot point or not?
Yes, that is a valid point.
Thank you, Professor. Can I also now refer you to the Weber article, the 2008 Weber article you referred to? Now that's on the screen as well. And I want to direct your attention to page 1852.
To which?
It's coming up on the screen. 1852. And on the second column, in the middle of the first main paragraph, beginning with the words "the current challenge," that will be isolated for you and us, Professor. Now, what the authors say there is that the current challenge, however, remains to determine the optimum methods for differentiating those cases that are truly infection from those in which the isolates might represent simple contaminants, post-mortem translocation or incidental colonisation. And then they refer to contamination being minimised with good technique, which you've given evidence of. And further they say, and I quote, empirical evidence suggests that contamination is more likely to result in a mixed growth, but there is little published evidence to confirm this at autopsy, and our results do not support this notion. Do you see that?
Yes.
Do you accept that conclusion?
No, but if you look at his paper from 2010, what you find is a comment that polymicrobial cultures decreased from 61% to 46% with increasing time from death to autopsy.
That doesn't change the conclusion reached here, does it, Professor?
So polymicrobial cultures can be valid,
But it doesn't change the conclusion that there is little published evidence to confirm this at autopsy. Is that right or not?
in his, as I said, in the 2010 paper, they addressed this.
But does the 2010 paper conclusion alter that conclusion, is my question to you.
I think it does.
And if so, if you can tell me the paragraph which indicates that their view has changed. You have a copy of it, I take it, the 2010 paper? Or are you relying on some reference in your report, Professor? And if so, perhaps you could tell us which paragraph.
In the abstract in the 2010 paper,
The abstract?
it says polymicrobial cultures decreased from 61 to 46%, chi-square for linear trend, 12.88, p is equal to 0.0003, and cultures taken 2 or more days after death yielded significantly fewer isolates per sample than cultures taken less than 2 days after death.
I understand that, but how does that differ from the conclusion reached in the 2008 article?
So I would say that there is evidence that polymicrobial cultures are more than artifacts and more than contamination.
Well, we'll need to look at these more carefully, Professor Blackwell, but thank you for your evidence in that regard. Can I turn to you, Professor Clancy? In your first report, you refer to paragraph 17 to the finding of the growth in blood culture in Patrick, Sarah and Laura. And you note that they're consistent with the recent findings researched by Professor Blackwell. Now, I think at this stage you hadn't actually received the microbiology reports. Is that right?
That's correct.
And then your next statement, the supplementary report, you had received those microbiology reports.
Yep.
And in relation to Sarah, paragraph 7, you refer to the bacteria found in her lung tissue as commonly present in children that die unexpectedly and without any readily identifiable alternate cause of death. and it's not unique but rather characteristic of any disorder where protective immune mechanisms are compromised. Now then you continue over the page to suggest that a confident diagnosis of SIDS on clinical grounds and the microbiological report adds confidence. Now, in terms of adding confidence, you also argue against post-mortem contamination. Do you see that?
Yes.
Now, you will have heard my questions of Professor Blackwell in respect of the evidence of the forensic pathologist, which was unanimous in respect of what was found in Sarah's blood cultures were contamination. Do you suggest that the inquiry should disregard or not give weight to the findings of those, the evidence of those forensic pathologists who either saw the cultures or read about them in relation to Sarah?
What I'm saying is essentially a couple of things. First, the presence of Streptococcus and Staphylococcus species in the airways is what you would expect if there was some defective clearance mechanism in those terminally normally sterile airways, that they would come down from the upper airway tract and normally be coughed up and got rid of, but they were there. And I think that's a real finding. I think the issue of the E. coli is one where a better argument, how strong that is, I think depends on the person you talk to. The forensic pathologists, I think, have a long experience of thinking bacteria so often, when there's more than one bacteria, as being contaminants, which is clearly not the case in the airways. And this is relatively recent information that no matter who you are, how old you are, if you have defective clearance, you will get those bacteria, and depending on the age, what type of bacteria. The younger person is more likely to get staph, the older person will get Haemophilus influenzae and things like that. And I feel here you've got strong data suggesting that's exactly what's happened in Sarah, and that has been a contributing factor in her death through, presumably, the production of toxins.
Can I just draw your attention to the last sentence on page 2 under paragraph 11? You say that the subsequent cultures of the spleen grew coliform, suggesting contamination of that organ at this later time by gut bacteria.
Yes, I think that's a stronger argument that this could be contamination, although from the more particular microbiological experience of Professor Blackwell, she can make an argument that I may not be correct there. But I don't think that same argument of contamination can be applied to what is found in the lung, because you don't get so much of the staph and strep. You're not going to get that very, very often at all from the gut at this age.
In relation to Laura, you have a different view, I think, from Professor Blackwell. In relation to Laura, paragraph 14, you say that the microbiological reports are very different, and you agree with the microbiological report that post-mortem contamination is likely to account for the coliform's presence.
Yes, I do. I think that my view would be that there a stronger argument in this case could be made that there was contamination, but I also believe that it's irrelevant to the cause of death.
Thank you. Thank you, Professor Clancy. I have nothing further, Your Honour.
Anything?
No, thank you.
Ms Richardson? Thank you. Well, thank you, Professor Clancy and Professor Blackwell. Thank you for coming, and you can go now if you want to. Thank you.
Your Honour, can I indicate two things? Firstly, those assisting Your Honour will put together a bundle of the reports referred to in oral evidence, and they will be circulated and ultimately tendered. Secondly, the inquiry obtained a report from Professor Rawlinson at the recommendation of Professor Blackwell in relation to what testing might be carried out now in relation to the children. And we obtained that report from Professor Rawlinson, and I tender it, but before I formally tender it, I might indicate that his view, and Professor Rawlinson is a senior medical virologist, is that although it is possible to perform sensitive molecular tests for infectious pathogens, including viruses, on the post-mortem material available, there exists highly significant issues regarding testing, interpretation and the conduct of the tests, which at this stage are not able to be resolved satisfactorily to make tests useful in determining cause of death in this case. And based on that advice and following Professor Blackwell's recommendation, nothing further was done. I tender Professor Rawlinson's report dated, undated, but it follows a discussion on the 28th of November last year with those assisting, Your Honour.
Exhibit X.
Now, Your Honour, that's the week of evidence of the forensic pathologist and our two witnesses.
Yes, you can leave the witness box, thank you.
Your Honour has previously made the direction that all reports in relation to the geneticists and the hearing which begins on the 15th of April are to be provided to the inquiry by Friday the 29th of March, and on the Monday the 15th of April to the Thursday the 18th of April, the week before Easter, there will be evidence of the interpretation panel, broadly described, as well as Professor Ryan, who, as Your Honour is aware, a report was provided last weekend from those assisting Ms Folbigg. Then the evidence of Ms Folbigg will be heard on the week starting Monday the 29th of April, most likely at this court, as will the forensic pathology, the genetics evidence be given at this court. Now, I submit, Your Honour, a program of submissions following the completion of that evidence, and that is that the submissions from Ms Folbigg's representatives be provided on the 31st of May, or by that date, which is 4 weeks from the end of the hearings, with counsel assisting submissions being available and provided on the 17th of May.
So that's on the basis that Mr Morris will have 2 weeks when he knows what your submissions are going to be.
And the prior 2 weeks to clearly
Yes,
prepare his own submissions. Now,
you have a problem with that, Mr Morris? Is that...
Your Honour, I don't think we will, because you can assume that we won't be leaving the preparation of submissions until the 17th of May.
I think that's probably right.
Yes.
So can we bring that back to the 24th of May?
Oh, Your Honour, I'd really appreciate that. It's an incredibly complicated area.
No, it's
And
just a question. You sounded so confident that I...
Your Honour, when it comes to written submissions, I don't have the same confidence as cross-examination.
well, 31st of May then.
Thank you, Your Honour.
Your Honour, I'm referring to Ms Folbigg's representatives, but clearly if anyone else with leave wishes to provide written submissions, the same date would apply to them.
Yes.
Now, given the experience over the weekend that I explained on Monday as to the very late service of material, I invite Your Honour to discuss with Mr Morris the intentions of those representing Ms Folbigg as to the provision or even the engaging of any expert not known to the inquiry?
Yes, I think it's certainly important that we know Mr. Morris. I think we've stretched a point in to allow you a bit of latitude because it is a complicated matter and a lot of experts, but we do need to have some certainty.
No, look, I understand you're on it. Firstly, can I indicate that our genetic team is struggling to get the report done at the moment, and we keep encouraging them, and we're hoping that we'll have something by the 15th.
By the 15th?
No, sorry, not the 15th, 29th of March.
Yeah.
Yeah, we're really moving heaven and earth to try and do it. And Your Honour, I'll let my friend know with respect to that. With respect to other areas of examination, Your Honour, the neurologist report of Ryan opens up the possibility, and this relates to Patrick alone, some congenital abnormality, and Your Honour, we have no knowledge yet of what potential congenital abnormalities there may be. And if that were the case, it will literally be, we're looking to try to identify whether there are any congenital abnormalities that are readily identifiable that may explain Patrick's death.
Right.
And to that extent, we don't have an answer yet, but I'll let counsel assisting know as soon as we're able. But this is a matter of high science. It's not readily capable of being identified. Your Honour, the other thing is that given that Ms Folbigg has now decided to give evidence, we are looking at reviewing the psychiatric and psychological evidence which was given at trial on the sentencing, or that formed part of the material that was forwarded to us by counsel assisting. And the fact is that there were some minor issues of things like Munchausen's syndrome by proxy, and I think there was also some analysis about the diaries. And Your Honour, I'll be reviewing that now that...
Well, can I say, Mr. Morris, that I would not be assisted at all in this inquiry by a psychiatrist who wanted to come along and tell me, A, what the words of the diary mean, or B, about the fact that a mother who'd lost her babies would be upset and emotional and so on. I mean, those are things that are readily apparent, I think, unless there's some other aspect of it that...
There were some features of the psychiatric evidence at trial which may be relevant.
Talking about Munchausen's?
Well, there was Munchausen's syndrome by proxy, which was mentioned yesterday, which is that syndrome whereby...
I know it well. I've raised it on a number of occasions as a defence lawyer. I've dealt with it as a judge on a number of occasions.
And there was evidence there at trial that there was no indication of that syndrome in the clinical records and in the history of these children. And to that extent, given that you remember we had the list of potential causes of ALTI,
Yes.
and one of them was specifically Munchausen syndrome by proxy. And
that would be... I'm sorry, not for me to to advise you about that, but it strikes me that would very much cut across your general submission. You'd be raising the possibility that well, I don't think I should,
No,
in court, go into it. But,
Your Honour, I don't have a formal concluded view about it, but there are some of these issues floating about.
but you can see what I mean, that hardly sits consistently with the denials.
Oh, there's no doubt she denies it. The thing about it is that there is, one of the possibilities is, that's been raised is that this was caused by Munchausen's by proxy, and the police psychologist who reviewed her said that there's absolutely no indicator. I mean, Munchausen's syndrome by proxy is an intentional act to inflict harm upon the child.
Yes, I know.
And if there's no history of it, if the police psychologist has actually excluded it, then it goes to the character of the woman. It suggests that there is not a pattern of behaviour which suggests that she's got any problem there at all.
It would be difficult to argue on the one hand that she had nothing to do with the deaths of these children, and then on the other hand raise the possibility that she actually did have something to do with it arising out of Munchausen.
No, we're not suggesting that she did. We're suggesting that she didn't.
But nobody's raised the fact that she did on that basis.
No, I understand. Your Honour, we may be at cross purposes, but look, I'll take Your Honour's observations on board. I've been asked to indicate what areas we still see as potentially being relevant and which may give rise to further information.
Yes. Okay.
Yes.
Well, I made observations about psychiatric evidence because there was a psychiatric report that was put forward in the petition for an inquiry, and that sort of psychiatric report is not something that should be of any assistance to the inquiry. Yeah. But anyway, I'll leave it to you, and we can talk about it later once you're in a better position.
Yes, and I'll liaise with my friend and we'll try and keep it moving along.
Well, with the greatest respect to my friend, advising Your Honour at this stage of the inquiry that there are issues floating around is not helpful. The final timetable has been set. The inquiry has been continuing for many months. The question of Munchausen's by proxy is, to be frank, Your Honour, bizarre to raise at this stage. No one has suggested, let alone me, that that is at issue at all. The psychiatric report that I suspect my friend's referring to was on sentence, so it was done on the basis of guilt. And for my part, Your Honour, assisting the inquiry, I will not raise any issue of Munchausen's by proxy, and there is no issue that has been raised in any of the material which is before Your Honour, in addition to the comments that Your Honour made. Secondly, in relation to congenital abnormalities, my friend is lacking in specificity as to what matters are being followed up, thought of in respect to congenital abnormality. Is it the case that my friend's proposing to engage experts in respect of this neurologist's report that there may be something other than a single hypoxic event that caused the ALTI? And if so, Your Honour, it is my submission that Your Honour should require those representing Ms Folbigg's interest to be clear and certain now, rather than a report from an entirely different expert land with the inquiry weeks later. And perhaps, Your Honour, if I can just add one additional matter. My friend has said that there, notwithstanding his moving heaven and earth, there are problems with the those on Ms Folbigg's side who are involved in the interpretation and sequencing. There have been many invitations and opportunities given to those to speak with Dr. Buckley, who's managing the process, or the inquiry about those matters, and that has not been forthcoming. In the event there are difficulties, Your Honour, I submit that those representing Ms Folbigg should be required to put in writing precisely what those difficulties are in order for those assisting Your Honour and Dr Buckley to do what they can to overcome whatever obstacle exists. And even though I said finally, there is one other matter, Your Honour. Finally, there has been ongoing issues as to Ms Folbigg being examined by relevant experts. I need not go into the detail publicly. That has not been completed for reasons unknown to the inquiry, and certainly the inquiry has done all they can to assist in that regard. Now, my friend has not raised that, but if that is going to be a matter that is raised at some future time in respect of matters that were, are floating about, then Your Honour should know it now.
If I can deal with the last point first, Your Honour, we have been trying to arrange through the prison some further investigations by an electrophysiologist to assess the cardiac function. And I think on Monday, we provided a letter asking for the assistance of the Commission to help facilitate that further examination with Justice Health. Now, Your Honour, that's been on the table between the two parties since Monday, when we were notified last week that he's having difficulties and he can't complete it. And to that extent, that is no secret. Now, if anything, we are hopeful that those assisting Your Honour will be able to assist us with that program, and that is a matter which is out of our hands, and they've been well aware of it. That's.
Well, I think we are. I mean, the inquiry's quite prepared to do whatever it can, but of course, we're generally speaking not in much better position than you are, except that through the Crown Solicitor's Office sometimes. But it has to be done through corrective services, of course.
Your Honour, might I just indicate, I apologise for interrupting, Your Honour has signed a letter to the Governor asking for that everything to be done that the Governor can do to provide access by Ms Folbigg to whoever she needs access to provide the testing. That's all that can be done by the inquiry. What I understand, and this has been conveyed to those representing Ms Folbigg for weeks, if not months, is that they have to obtain the referral to an appropriate person. The inquiry can't refer Ms Folbigg to somebody. Those representing her have to refer her, and we, through the Governor, will ensure that she is able to go to that appointment. But we cannot make the referral, we cannot make the appointment. That is a matter for them.
Your Honour, as I understand the position, the referral has been made, and the person to whom the referral has been made is saying he is having difficulty getting access to her. So, Your Honour, I'm happy, rather than... It may be that there's a cross-communication here, and I'm happy to liaise with counsel assisting to try and sort it out.
Maybe the letter to the Governor should be sent to the person who's having the trouble so that he or she can use it to deal with the prison authorities. Corrective services, I suppose. And they're a separate organisation.
Yes, I understand, Your Honour.
But if you've got a copy of the letter, and if the person who needs the things has a copy of the letter, then have you got a copy of the letter?
I'm not sure that I've got... look, Your Honour.
Anyway, you can use the letter that we've sent to the Governor, and that's as much as we can do.
I understand, so and we're grateful, Your Honour.
So that's probably the way you should go about doing that. Yes. As to the rest of it, we really are working to a timetable now, and if you If there is anything else that you want, or you really ought to advise us, may not necessarily be in writing, but we need some specifics about what the problem is within the next 7 days, really.
Your Honour.
And we need an explanation of why, if you have some particular problem. Or we need to know that so that we can then perhaps have a mention and assess where we're going from there.
Yes, Your Honour.
So if you can tell us within the next, by the end of next week,
Yes, Your Honour.
then we'll work it out from there.
Thank you, Your Honour. Thank you.
All right. Thank you, and we'll adjourn.
Thank you, Your Honour.
Temporary adjourn.